Hello, and welcome again to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier consisting of review articles centered on a major topic important to surgical oncologists. I'm John Vasallo, managing editor of the series here at Elsevier, and for our 11th podcast, we'll be discussing the January 2024 issue devoted to hepatocellular carcinoma. Patients diagnosed with hepatocellular carcinoma are a heterogeneous group. So this heterogeneity requires a multifaceted cancer care approach, including surgical, loco-regional, systemic, and supportive treatment options. In this podcast, we will discuss some of these options with 4 articles from this issue. Leading this discussion will be our consulting editor, Dr. Tim Pollack, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editors of the hepatocellular carcinoma issue, Dr. Adam Yop, professor of surgery and Occidental Chemical Chair in Cancer Research at the University of Texas Southwestern Medical Center in Dallas, Texas, and Dr. Majella Doyle, professor in the Department of Surgery at the Washington University School of Medicine in St. Louis, Missouri. Welcome to all 3 of you, and over to you, Dr. Pollack.
Hey, John, thank you so much. I'm really excited to have Dr. Yop with us today to talk about this fantastic volume that he and Dr. Doyle co-guest edited on hepatocellular carcinoma. Obviously HCC is a very prevalent cancer and is also with a high case for fatality, being the 3rd leading cause of cancer-related deaths worldwide and amongst one of the fastest rising causes of cancer-related mortality in the United States. So I think this is a very topical and timely topic for surgical oncology clinics of North America. So, Adam, welcome. I'm excited to have you with us today.
Yeah, thanks for having me. Anytime we can talk about HCC, it's a good day.
So let's maybe hop into it. I have 4 papers that I've picked out today. I'd like to get your thoughts on. And the first paper, actually, it's your paper. You wrote this with Dr. Chang. And this paper addressed expanded indications for surgical resection of hepatocellular carcinoma. And obviously, surgical resection is a key cornerstone of one of the therapies that we can offer to patients with HCC. But it can be challenging because, many patients may have some underlying liver disease, insufficiency, whether it be, MALD, fatty liver, fibrosis, cirrhosis. So I was wondering if you could take us through a little bit, just some of the preoperative assessment that you touched on in the paper that surgeons should be thinking about when considering patients for resection of HCC.
It's an interesting cancer in that it's not really so much about, you have to take the totality of the patient into consideration from the underlying liver function as well as the tumor burden itself. So it's unique in that situation. And as we kind of touched upon in the article, it's really looking at the preoperative liver function, making sure not that when after surgical resection that you're leaving enough functional liver behind where a patient doesn't decompensate or where you tip them over from because the reality is in the United States, most of the patients are cirrhotic that we see. And so you're trying to balance that component to it. So typically we'll look at as a surrogate for portal hypertension, a platelet count. And some of the data done by the group at Emory with Shishir Maitel's group is 100,000 platelet count seems to be kind of this magic number where you can operate and resect those patients without them tipping over to decompensation. And then the second thing we'll look at is underlying liver function. So typically most of the liver resections that are done are done for Child-Pugh A. So essentially people without ascites, no hepatic encephalopathy, normal bilirubin, and the like that. And then you're looking at how much liver you're actually leaving behind. So typically, there's a lot of data, and we just use future liver remnant. We're much like everybody else in the United States. We don't use the hepatic wedge pressures. Very difficult to do within the United States being an invasive test, and it is a good surrogate for functional liver remnant volume. We just measure the actual the volume of the remnant liver, and if it's greater than 40%, the data shows that really the amount of decompensation seems to be fairly reasonable and low.
Yeah, I was going to ask a little bit about that, just around anatomic or volumetric criteria versus functional criteria. You did touch on ICG in the paper, and I know that's more predominantly used perhaps in Eastern countries such as Japan. But I was wondering if you could maybe comment on volumetric versus functional criteria.
Yeah, I think you hit the nail on the head. I would love to be able to do ICG or measure, the functional reserve using ICG. Unfortunately, within the United States, outside of clinical trials, it's not useful or it's not used. So in the Asian studies, if your ICG retention is greater than 30%, then really you can do limited resections or ablative techniques without tipping the patient into decompensation. So typically what we'll use mostly is just volumetrics. And us, like the data out of the group from MD Anderson with Nick Botte's group, using the functional liver remnant as measured by formulaic with the body surface area seems to offer the best benefit as measuring the volumes itself, instead of doing the venous pressure gradients as a measure of portal hypertension.
Yeah, so we've been talking a little bit about the kind of the non-tumorous liver, if you will, and you've highlighted the importance of platelet count, bilirubin level, and then kind of assessing the functional reserve of the liver by using volumetrics. I wonder if we could pivot maybe a little bit to talking about the tumor itself. And you also, in your article, touch on some of the tumor-specific factors, multifocality, presence of macrovascular invasion. And I know in particular, there's some kind of controversy, if you will, that still exists around the BCLC-B group, which is this kind of intermediate group. And I was wondering maybe if you could comment a little bit on decisions around resection relative to tumor size, tumor number, presence of vascular invasion.
Yeah, I think that's the crux of the matter is after you determine when the patient actually can undergo a resection based on their underlying tumor function is now you're looking at the tumor burden itself. And I think the best way to look at that is the multifocality issue. So more than one tumors, which will move you from a BCLC A or 0 stage to a B stage, and then looking at from a tumor macrovascular invasion or microvascular invasion, which puts you in a BCLC C stage. The data, I think, most of the data is coming still out of the Asian countries as they have more experience with tumor resection or hepatic resection for HCC. And I'll touch a little bit upon start probably with macrovascular invasion. So I think you have to look at it as far as classify what level of macrovascular invasion you have. I think the easiest kind of staging system is still to look at the liver cancer study group of Japan classification, where it's broken down into BP1 through 4. And really, they've done a great job with looking at over 20,000 patients that underwent or presented with HCC within Japan, and actually look through how patients did after resection with tumor macrovascular invasion. And the data was really interesting in that patients in BP2, so BP1 essentially just being segmental thrombus within the portal vein, and BP2 being second order. So essentially on the right side, it would be like a right anterior posterior portal vein thrombus. Those patients after surgical resection don't do that bad, surprisingly, with looking, and again, in Japan, most of these patients either have now MAFLD or hepatitis C, and the median survival are measured for BP1 just over 4 years, and for BP2, 2.5 years. So I think the important thing to look at with that is really what are your other treatment options? So by the Barcelona clinic classification, whether you believe in that or not, really it's systemic therapy is recommended. And so when you compare surgical resection in well-selected patients versus giving systemic therapy, and standard of care systemic therapy is at this point, atezolizumab and bevacizumab, the survival is not that great. And there is an added benefit, or seemingly a greater benefit, with surgical resection versus systemic therapy in that subgroup of well-selected patients. Obviously, it's well-selected patients. With tumor multifocality, I think the data is a lot less mature. And I think it's just because most of those patients are still looked to bring to the transplant field. So the macrovascular invasion is very easy. They're not eligible for transplant. The vast majority of them are not going to be downstage to transplantation. And I think Neil Mehta hits that in one of his articles, where I think he uses the words it's a pipe dream to downstage portal venous tumor thrombus to transplant. But for multifocality, I think it's a little bit easier, and most patients still are kind of pushed that way. But there is a definite benefit in folks with multifocality. Again, in well-selected patients, you're still looking at overall survivals at 5 years, anywhere between 18 to 70%, depending on their risk classification.
So you touched on this systemic therapy and Tazo and Bev, and it's very exciting time, if you will, for hepatocellular carcinoma after decades and decades of not really any agents with much efficacy. Immunotherapy with checkpoint inhibitors has shown some strong anti-tumor activity in a subset of patients in the combination of the anti-PD-L1 antibody, TEZ and VEGF neutralizing antibody Bev has really taken center stage for patients with, advanced disease. Is this other article included in the volume from Dr. Whittam and Haishan discussing the role of neoadjuvant therapy prior to curative intent resection for hepatocellular carcinoma? And in that article, they highlighted, the role of neoadjuvant immune checkpoint inhibitors. And I was wondering if you could comment maybe just a little bit on what your perception is around the role of ICI therapy for HCC in the preoperative or neoadjuvant setting.
Yeah, it's incredibly exciting times. Up until recently, it was just sorafenib et al. For advanced tumors. And now as we've kind of moved into the IO space with the atezolizumab and bevacizumab in an advanced setting, and now with the adjuvant trial, the IMbrave050 trial being positive in an adjuvant setting, the real next step is the neoadjuvant niche. And so there's been some very cursory data that's come out. There's 3 kind of not real large studies, but I think very well done and thoughtful studies giving a combination of drugs or IO therapy by itself. And I think they're more provocative than anything else at this point. The most patients that were accrued in any one of the studies was out of the Mount Sinai group by Tom Marin, and they only had 20 patients giving Libtayo or a PD-1 inhibitor to 20 patients that were deemed resectable. And there's a lot of questions, which is it's actually great. We're 20 years behind in HCC, breast, and some of the other solid GI malignancies, but it brings in the questions of what are the proper endpoints for neoadjuvant therapy? How much neoadjuvant therapy should we actually be given? We taking patients that are resectable, giving them neoadjuvant therapy. If they have any issues tolerating the therapy, then you've kind of lost the window to resect. And then really what kind of in the article drives as well as what is deemed as being resectable. I don't think anybody even knows what that means right now. So it's an incredibly exciting times. And right now, all the drug companies are in the process of rolling out their neoadjuvant trials, which it's exciting as well. So,
yeah, I think you're right. It is really exciting. I think the data for advanced disease and even in the adjuvant setting, this is a natural progression to move it forward into the neoadjuvant setting. I was wondering your thoughts about which patients might we consider for neoadjuvant therapy, in HCC. And kind of making a slight transition to the next paper I wanted to talk about is around liver transplantation for hepatocellular carcinoma. And so I was wondering maybe your thoughts even around, immunotherapy in the setting of not only anticipated resection, but also potentially prior to liver transplantation.
Yeah, I think it's what patients should be given neoadjuvant prior to surgical resection. It's hard. It's right now, it's in the previous data with the three large papers that we mentioned, or that are mentioned in the articles. It was kind of all comers for the most part. And so the thinking is we're designing these neoadjuvant trials is, should we be using the data based on the IM-Brave 050? So patients who are going to have higher chances of recurrence. So people with portal venous thrombus right up front, patients that have large sized tumors. So there is some data that hasn't been published as of yet. So this will be a scoop actually for the surgical oncology clinics of North America. That there's a staging system called up to 7. So number of tumors and size of tumors greater than 7. So in those patients, they actually have the greatest benefit with adjuvant therapy. So in the IM-Brave 050 trial, there was a lot of kind of criticism that there wasn't a great benefit in an adjuvant setting. But if patients were above the up to 7, so they had multiple tumors greater than 7 and outside of Milan criteria, so not eligible for transplant, patients did incredibly well with atezolizumab and bevacizumab or adjuvant therapy. The thinking is those patients probably would do even better with neoadjuvant therapy, just based on some of the data from the melanoma, the Keynote trial with Pembro, thinking that you have the neoantigens in place, you're going to drive the tumor response. So those are the patients typically that will push for neoadjuvant therapy, the large tumors and the large tumors and the multifocality tumors.
Great, thanks, Adam. We've been talking a lot about immunotherapy, rightly so, because that is such an exciting, emerging area of therapeutics. I did want to talk maybe a little bit with Dr. Doyle about perhaps some of the more tried and true, if you will, other modalities for downstaging or bridging as related to transplantation. So I was wondering, Majella, if you could just talk a little bit about what you see as the role of embolization, whether it be bland or chemoembolization or ablation, relative to downsaging or bridging when it comes to transplantation for HCC.
When we look back at the original sort of Milan criteria and consideration for transplantation, after 1996, there was a lot of efforts for expansion in tumors outside of Milan to consider for transplantation, and a lot of those early studies didn't have any role of local regional therapy, or a lot of them the patients hadn't had local regional therapy, and so I think some centers like our own began having a strong interest in downstaging, or at least downsizing and treating tumors that were bigger and outside of Milan and having good results. And, several centers and groups have shown that if you do treat the tumors that are outside of Milan and downstage them, that they will do just as well as patients who are within Milan. So that's kind of like, the short background of downstaging. The most common use of downstaging before we had Y90 or intraarterial radiation therapy or TARE was TACE and bland embolization. And I think TACE was most commonly used, although centers who were using bland embolization. So I think TACE was probably the most common. Ablation for me for downstaging, it just doesn't work very well because it's only really suitable for smaller tumors. And so I feel that it's really local regional therapy with either TACE or now I think Y90 has become really in many places, certainly in the US and North America, has replaced TACE, and I think for good reason. The results seem to be very good. The response rate, the response to therapy is good with Y90, and it takes less doses, and it seems to be well tolerated by the patients. So I would say in today's era, Y90 is probably the most commonly used in North America in busy transplant centers. TACE is still used in some places, and particularly in other places in the world where Y90 may not be available. And ablation is less commonly used because of the size of the tumors that ablation can successfully treat are small, and usually would be within Milan or certainly within UCSF, and I would not be really considered a downstaging procedure per se.
And I was curious, in your experience at WashU, after you've treated patients perhaps with the local regional downstaging, whether it be with TACE or TARE, what type of response are you looking for? I mean, you're following the AFP, what's the drop you're looking for? And then also from an imaging point of view, as you know, sometimes by RECIST or even modified RECIST is not a lot of change in the size, at least initially. It may take some time, especially with TARE. So are you using functional imaging? Do you use MRI? Do you favor CT? What's some of your insights on those topics?
Yeah, that's a great question. I think using both biological factors, as in really is AFP, and imaging features, which is modified RECIST. And so we tend to use MRI here most commonly. I think some centers use CT. It's kind of center preference, really. But, you're absolutely right. And it's a great point because, if you're trying to downstage or downsize an 8 or a 10 centimeter tumor, you're not necessarily going to shrink that tumor, but you're going to shrink the active area of the tumor. And that's what we are really looking for, that like active enhancing portion of the tumor. And that's what we measure. And that's how we get the patient's exception points is, if they're within, it's kind of like a new UCSF criteria. So it's a little bit beyond UCSF criteria. And if they're within that and they get treated and they downstage to within Milan, and that the enhancing portion is within Milan, then they can get automatic exception points for transplant. And those patients do very well. So yes, we're not measuring the tumor, we're measuring the size of the enhancing area. And I will add that there's quite an amount of data out there looking at partial response and complete response to therapy. And it's interesting that patients who have a complete response do significantly better than patients who have a partial response. But there's some data out there that even a partial response can be worse than no response, and it's certainly worse than a complete response. So I think the response to therapy is very important. And I think the latest in transplant has brought in AFP into the picture much more, because it used to not be a feature of getting exception points for transplant. But now if your AFP has to drop below 500 in order to qualify, along with the downstaging features. So I think that's an important sort of advance, that we're actually looking at the biology as well as the response to therapy.
That's great. And, before we leave your paper, we talked a little bit about immunotherapy, and we've talked a little bit about other local regional therapies. And I know there's a section in your paper that, touches upon, is there a role for a combined local region in immunomodulatory treatment? And I was wondering if you have any comments on that.
I think there definitely is a role. We are involved in a study with a Cincinnati group as well, looking at that exact question. There are several other studies that are ongoing. So I think that will be a question that will be answered soon. And I think it's a very exciting area. When you this was not published, so it's not in the issue, but I know there's data going to be coming out of Mount Sinai, just looking at patients who have downstage with immunotherapy or without local regional therapy. But there is a 45% response rate. So I think there is definitely a role for the combined therapy. One of the things you have to be careful of with transplantation after immunotherapy is rejection. And so you want to have that wait time after the patient has received immunotherapy before you think about transplant. So that's kind of an important thing to consider, that there were some early cases of rejection in patients who were going straight to transplant. And but it's been shown to be safely doable now, but you have to have a wait time. And the average wait time is about 3 months.
So that's fantastic. Thank you so much, Dr. Doyle. So I wanted to continue along the lines of talking a little bit more about transplantation, and just highlight the article by Dr. Yilma and Dr. Mehta talking about the optimal liver transplantation criteria. And this kind of goes back to the age-old debate, that has been going on for, probably forever, 20 years, about, resection versus transplantation, and trying to figure out, what's the optimal patient to transplant and who should be resected. And I'm wondering if perhaps you could give us your opinion on that, and especially in light of maybe perhaps some of the changes in even the organ allocation process or the rise of living donor programs. What's your perspective on this?
So I think, there are some that it's very clear, right? If you have portal hypertension, bad liver disease, no question, you're going to go down the road of transplant. If you have no liver disease and you have a resectable tumor, you're going to have a resection. So I think those are not the ones that are challenging to make a decision on. My feeling, and what we have practiced here, is multifocal disease is particularly in the background of Hep C, even if it's been treated, is probably a better. The patients are better served with transplantation. But there are centers, and there is data out there that resection is also acceptable in some of these patients. I think if you have a single tumor that's small, 2 centimeters or 2.5 centimeters, those patients could certainly be resected or ablated, and with great results, and hold off on transplant. And so my feeling is that sometimes we transplant too many patients too early, and these patients should be considered for resection, and that we should really be thinking about the patients even who are beyond UCSF, who downstage, who are very challenging to get them points in the USA, but they're transplanted in other parts of the world very successful. So patients who are very early should be resected. And now, in the past, if you resected those patients, they didn't get any points benefit for transplant. But now, if you resect those patients and they recur, they actually will get the exception points based on their primary tumor. So they don't lose out and they don't miss out on transplant, and you can actually save some organs for other people. And you raised the point of allocation, and there have been some changes in allocation, and patients with HCC, based on the changes in allocation, still some parts of the country have higher MELD at transplant. So patients who have cancer may not be as prioritized as they are in other parts of the country. And so in many parts of the country, resection is more common than in other parts of the country. And I think centers have different practices based on their location.
One other final question I had for you kind of relates to transplantation, maybe more in general, and it's just this, the kind of rising utilization of machine perfusion strategies in liver transplantation. And since we have you here and you're such a national expert in transplantation, I'd love to get your perspective on that.
So there is a lot of innovation happening in transplant at the moment. You mentioned living donor, and so I think living donor is a great consideration for transplantation. So as I mentioned, patients who are beyond UCSF criteria, who downstage, do not get exception points in the US at the moment, and automatic exception points. Yet we and many others know that those patients will do just as well with transplant if they downstage. So we have to look at ways of getting these patients transplanted. And one of the ways we can do this is by using livers that have been turned down or discarded. And so we have a trial called Restore, and it's using machine perfusion to perfuse livers that have been turned down by other centers. And we put the liver on the machine. It perfuses warm blood through the machine, and we could do viability testing on the liver, looking at bile and lactate and other features that we judge to sort of see the liver viability. And with that, in our trial so far, we've about a 75% rescue rate. And so that's one way to sort of increase the livers using machine perfusion. And then another interesting thing that has been popularized now in transplant is using normal regional perfusion. So the patients who are DCDs, and these are the kinds of donors that are not brain dead, so they can't be declared brain dead with their injury. And so care is withdrawn from those donors, and they're declared dead by a physician that has nothing to do with the transplant team. And then either the cardiac or the abdominal team come and put the patient on normothermic regional perfusion, where we clamp off any vessels to the brain or to the head, and we perfuse blood through the organs. And so that in utilization along with machine perfusion is definitely a way to use more organs, particularly I think liver, heart, and lungs, that are often not used in many donation after cardiac death type donors. So it's really game changing with the number of organs that we're getting for patients.
Well, Dr. Doyle and Dr. Yop, this has really been a really wonderful conversation with the both of you. I want to thank you for guest editing this outstanding volume of Surgical Oncology Clinics of North America. Congratulate both of you, and also just the wonderful group of co-authors that you amassed to put this together. I think this volume will be a very important resource for any care provider who is treating patients with hepatocellular carcinoma. So once again, thank you both for your time today and your efforts on behalf of Surgical Oncology Clinics of North America.
Thank you for joining us for this Surgical Oncology Clinics podcast devoted to hepatocellular carcinoma. The 4 articles discussed, as well as 9 others, are in the January 2024 issue, Volume 33, Number 1. The series is available for individual print or online subscriptions. Visit www.surgonc.theclinics.com to subscribe. This series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter at Surgical Clinics, and you can find our podcast on YouTube and your favorite audio streaming platforms. Thanks for listening.